Well, welcome, Daniel Dawes. I am so thrilled to be able to have a chance to speak to you about your work. You are one of our speakers for Community Grand Rounds, which is a speaker series that we launched about three and a half years ago at Spectrum Health Lakeland to increase awareness around the relationship between structural racism and health. Thank you for joining us.
It is my pleasure to be with you. Thank you so much, Dr. Todman.
Thank you. Daniel Dawes is the director of the Satcher Health Leadership Institute at the Morehouse School of Medicine in Atlanta, Georgia. And he is also a professor of health law, policy, and management. He has an extensive resume that I won't get into the details of right now, but suffice to say that he has been a long and strong advocate of health equity for many, many years. And I am proud to call him a colleague. I am thrilled to be able to allow you to share news of two significant appointments that you have recently earned. Please share with our audience these two new developments.
All right, thank you, Dr. Todman. Well, I'm really humbled and I am excited about these two appointments. One is election into the National Academy of Medicine, and the other one is an appointment to the CDC's advisory panel or advisory committee to the director. And I'm really excited about them because I believe they give me an opportunity to continue to delve deeper into the issues that we're going to be talking about today, to really move that needle of health equity forward to a degree that we've not been able to in public health and in healthcare. So very excited about those, and I want to thank you for your support.
That's exciting, and I'm excited to know that somebody with your background, your passion, is going to be at those tables helping to make decisions that impact the lives of all of us. So with that, I will start with our interview.
Right.
So can you share with me and our audience, what are the political determinants of health?
Yeah, that's a great question. So, we got to grapple with this concept. I think a lot of us, inherently or otherwise understand what the social determinants of health are, the structural conditions in which we are born into, we live in, and we die in. That affect all dynamics of health, quite frankly. But, we haven't quite finished the equation if we are truly going to the source of these health inequities that we experience downstream. And so what does that mean? Well, for every social determinant of health, there was a preceding political determinant, right? That created or perpetuated or is exacerbating these health inequities. And so I define the political determinants of health as involving the systematic process of structuring relationships, of distributing resources, and administering power. And they operate simultaneously in ways that mutually reinforce or influence one another to shape opportunities that will either advance health equity or hinder health equity. So I look at it as a three-pronged definition, right? The structuring of relationships, the distribution of resources, and the administration of power. And what does that mean?
Go for it.
All right. So, when we think about structuring relationships, I think about it in terms of the impact that laws and policies have had on population groups in the United States. So when I'm doing my analysis, right, to understand whether an inequity is systemic, unjust, avoidable, I'm looking at it through the buckets that I mentioned. So how have laws structured relationships? In society, there are the Homeowners Loan Corporation Act, the redlining law, as we call it, right? There are the anti-miscegenation laws that were designed in this country to prevent Black and whites from mixing, or the blood quantum requirement laws that were designed to ensure that indigenous populations would not interact or mix with the other population groups. Very interesting, but there are a host of other laws. If you work with people with disabilities, we know that there are policies that were effectively designed to ensure that children, right, were prevented from getting educated in our schools or having accessible housing in communities that are still on the books today. So there are past as well as present policies that are structuring those relationships. When you think about distribution of resources, I think about it in terms of the appropriations of federal and state and local funding, right? Discretionary and otherwise, or programs and services, healthcare, public health services in our communities. And notice that there's a dearth of these resources in communities of color. And then lastly, the third prong is looking at the administration of power. How do we concentrate power in a few communities? How is that designed? How is it done? Of course, we talk about this from the idea of redistricting and gerrymandering, from restricting ballot access and voter suppression tactics and the like. So those pieces, when we look at voting on the front end of the political determinants of health, they all matter. And collectively, they do impact our ability to advance health equity in America.
That's fascinating. And I remember when your book came out a few years ago, intuitively, it appealed to me because I knew that the thinking around the social determinants of health was incomplete, but I didn't have the language to describe that incompleteness. I didn't have the words, and your book really helps put language around those missing elements of the narrative around the factors that impact people's health. You talked a little bit about some of the examples. Can you link political determinants to things that perhaps are a little bit more tangible for people, like the quality of our water and air, water supply and air? Lakeland serves a community, Benton Harbor, that has been in the news for high amounts of lead in its water, for instance. If you could link the political determinants to specific factors that we know impact people's health, the food supply. You talked about the housing stock, but also I'd be interested in maybe labor, employment, for instance.
Yeah, no, very good question. And we talked about the social determinants, their environmental health determinants, behavioral health determinants, healthcare is a determinant of health, genetics, et cetera, right? And collectively, we know that there are these multiple interacting determinants that determine the quality and the extent of our lives on this earth. So your points are well taken. We talk about air pollution, right? Water pollution. There's climate change. There's toxic waste sites. Unclean water, a lack of fresh fruits and vegetables, and unsafe, unsecure, and unstable housing that many of our neighbors and our patients and those in our community really are challenged with. So yeah, they do increase our stress, quite frankly. They expose us to harmful elements, and they limit our opportunities to thrive if we don't manage them well. Well, in terms of how I see this, it is an issue that we can no longer ignore. So, I think it is really important that as we think about the structural conditions today, as we think about, the polluted waters, our polluted air, how did they come to be in the first place? Why is it that Black and brown individuals in the United States are breathing in the most polluted air, drinking and bathing and washing their clothes in the dirtiest of water? Why? This is not an accident. Mm-hmm. It is intentionally done. And it's an act of policy that has led to the results. So I want to use the examples that you brought in, and I'll bring in, of course, air, for instance, as an example. The fact that we know that there are higher rates of asthma in communities of color across the country. Well, through the social determinants of health framework, we've been able to link that in public health to these infrastructure, right, that exist in our communities. For instance, if you are, wherever you are, you may have noticed in the community that there's a major highway splitting right through the community, basically breaking up the community. Or you may have noticed a railroad track that again splits the community in half. You may have noticed a disproportionate number of bus depots that were placed in a Black or brown community in this country, or parking lots and other infrastructure, right? And yes, we've been able to determine that we are breathing in polluted air because of these social determinants of health. But that's not the complete picture, because for every one of these infrastructure that were placed in these communities, it's not that these Black and brown communities decided to build around them. No, they were there in the first place, or they were forced into these areas in the first place. And then the infrastructure came afterwards by an act of policy decision. Usually not only at the federal level, but at all levels of government, federal, state, local levels, right? Working in concert. So the Highway Act, for instance, basically gave birth to the highway system that we see running through our communities. We have the Housing Act that created the Urban Renewal Program that led to displacement over 500,000 African Americans in this country of ours. So again, when you really dig down a little bit deeper, you look back right in history, you dig down deeper, you can see the impact that these political determinants have had, and really and truly, we can connect the dots then from all of these multiple determinants and how they are undergirded by a political determinant. You brought up water again as another issue in communities, Flint and others, right? We have seen and heard this time and time again in Mississippi. They're dealing with a similar crisis like you all have been dealing with, as you just mentioned. And again, it's owing to what? We're going to switch the water supply, another policy decision, to save costs, is what the argument usually is, right? Or for some other reason, right? They allow the infrastructure, the piping, to rust out. They aren't a priority community, right, in the eyes of the policymakers, and that then leads to the poor health outcomes that we are seeing. So, simple things like access to water, clean water, access to clean air, they're all politically determined.
Yes. I grew up in Chicago, and I later learned that the house that my grandmother lived in was once on the Dan Ryan.
Oh, wow.
When the decision was made to build the Dan Ryan to give access to downtown from suburban communities, those houses were removed. And in removing those houses, they broke up social networks that we know are critical to health. That was a federal policy, federal transportation policy decision.
Yep.
that frayed the cohesion of an established African-American community in Chicago, and many along that route, as a matter of fact.
Oh, absolutely. And we didn't even get into the one of the major policies that we've all been talking about, which is redlining, the Homeowners Loan Corporation Act, right?
Yeah.
So as if these communities hadn't already been starved of the resources that they need to survive and thrive in our society. No, there was another policy that decided to go in and grade the neighborhoods in Chicago, right? And in Detroit and Grand Rapids and other communities or cities across our country. So, when you look at those things, it took an act of policy that again decided to, grade and color code these communities. Yeah. And then once those studies were aggregated, they were then used to create additional policies, deciding who would benefit from these social and economic policies, right, that we're ensuing. So it's a fascinating story, I think. And if we truly want to move beyond nibbling around the edges of the problem of health inequities, if we really care to do that, then we've got to go to the instigator of these results that we see, right? To the causes of the causes, the root causes, in fact, of these inequities.
As I listen to, often I hear people say that one of the solutions is education. And I'm curious if you have any insight or can share any insight on the policy decisions at the federal level, for instance, that predisposed the schools that serve Black and brown kids to be under-resourced. I know, for instance, in some areas, school funding is linked to the property values. And then if you have depressed property values because banks and insurance companies won't invest, that has implications. Can you talk at all about that, those relationships?
Yeah, absolutely. So it's interesting. You're forcing me now to look at the big P policy and little P policy, right? You have the governmental policy, and then you have the non-governmental, right? Or those commercial policies. And I find that area of education to be quite interesting, because you're right. We just talked about the Homeowners Loan Corporation Act, that red line. We talked about the ensuing starvation of resources, again, in these communities. And it's a timeless strategy in this country. In Atlanta, Georgia, we're still dealing with this now with a more affluent community, Buckhead, making whispers about wanting to cut themselves off from Atlanta, which would then cause a depletion of resources into other communities in the Atlanta metro area. So you see that again and again in this country playing out. Well, I would argue that in terms of education, it is a critical determinant of health, critical aspect of the social determinants of health. It is the great equalizer, right? But we do know from David Williams's work, and I know you had him on in the past, and other scholars and researchers in the social determinants of health movement who have studied education and economics, and have found a very striking disparity, right? When you look at, even with education, why is it that all things equal, Black children still fear the worst, right? Economically and otherwise, in terms of health. And there is something to the root of all of this, right? It is racism. Racism truly is at the root of this. Arlene Geronimus, Dr. Geronimus at the University of Michigan in your state, has coined the term biological weathering, and she's shown with other epigeneticists just how our bodies, right, age very rapidly, owing again to these isms, right? Classism, sexism, ableism, racism, you name it. And
she was one of our speakers too.
Oh, was she?
Yes.
Oh, very good. Yes.
Company.
Oh, very good. Okay, so you've heard from the best, those who really have opened our eyes in research to the causes and how these things have impacted our health over time, and then leads to premature chronic diseases, right, in our body. So I think it's a very fascinating thing, and I think through their work, what they have shown us is that all things aren't equal, and in order to realize healthcare equality or health equality, we're going to have to really employ an equity lens to this work to remediate the past, right? To repair the past of ours that led to the unequal distribution of resources in our schools, and has led to the poor educational outcomes that we see. That again, when you compound this with everything else, leads to what? Worse economic outcomes, worse health outcomes, right?
Right.
The list goes on.
This is fascinating. And we could go on and on and on. I just have a couple more questions for you. What can you tell us about Biden's health equity agenda? Is there anything you can share?
Yes, absolutely. So, I'm really excited. I'm usually politically neutral, and I'm an individual who looks at the facts. And what I can tell you about the Biden administration is that, for the first time in U.S. history, we now have an administration that when Biden was actually campaigning for the seat, explicitly promised that he was going to center equity across the board, right? He was going to prioritize this in public policy. Well, President Obama was the first presidential candidate in U.S. history that explicitly prioritized the elimination of racial and ethnic health disparities. We thought, as health equity champions, as those who are, really advocating to elevate the health of all population groups, whether you are white, Black, Latinx, Asian, Native American, you name it. We want every single population group to be able to reach their full health potential. Well, easier said than done. And as we just mentioned, as we were just discussing, there are a variety of factors that prevent us from achieving that. So key among those are the political determinants of health. And it is an area now that we have an administration that recognizes, right, how the past has led to all of these results, how those who were in their seat prior to them, whether Democratic or Republican administrations in the past and members of Congress, there is no party that is immune from racism. Let's be very clear about that. And I would say there are policies that were developed by politicians that created the conditions that we find ourselves in today. So what the Biden-Harris administration has committed to doing is to centering health equity, making it a cross-agency agenda. We see the U.S. Department of Housing and Urban Development, the U.S. Department of Health and Human Services, the U.S. Department of Education, Transportation, Justice, you name it, coming together and saying, what can we do to address the social and political determinants of health? What do we need to do to repair the past? And they're looking at it from housing to, as I mentioned, education, to the issue of transportation, which is a big deal in our community, to healthcare, right? And seeing what we can do to increase access to healthcare, increase coverage, to increase remuneration or reimbursement from Medicare and Medicaid for providers that actually are engaged in uplifting the health of all members of their community. And so what the Biden administration has been doing is, since he was inaugurated president, immediately after, as you know, he signed as one of the first executive orders, one to address health inequities and to establish the Health Equity Task Force at the White House. That task force has been working around the clock under the leadership of Marcela Nunez-Smith, Dr. Nunez-Smith, and they have brought in folks really to think about what are the most pressing issues. What do we need to do to truly achieve health equity in the United States? And so they basically have compiled a list of over 300 recommendations. And right now, they are working to prioritize and synthesize and focus, to get a transformative, cohesive, and achievable slate of recommendations. And in terms of the 300 recommendations, they have synthesized them into 9 areas. So number 1 is collecting, sharing, and using data. We've talked about this, Lynn, that if there is no data, our policymakers and leaders, healthcare leaders, say there is no problem. Right. We know that is simply not true. There is a problem. We need the evidence. And so we are going to be working on standardizing data collection practices when it comes to race and ethnicity, to make sure that our data collection systems really talk with one another, right? There's interoperability. In terms of that. Mm-hmm. Absolutely. And that the agencies, so Department of Housing and Urban Development, they're sitting on rich data when we talk about the social determinants of health, right? And HHS and HUD haven't necessarily communicated in the past, right, and shared this stuff. So now there is an attitude of wanting to harness that power of collaboration and to figure out how we can leverage these data sets, right, to really finish the picture, to complete the picture. So that's exciting. Data collection, you'll see, is a major one. Coordination and collaboration. How do we get these various industries, these sectors, right, governmental and non-governmental, to communicate, to work together? How do we get healthcare and social services and public health and others to come together and really think about how we can address these determinants of health in a manner that will elevate the health of our most vulnerable people and marginalized communities? Then we're going to be looking at, I know you had mentioned workforce, right? And we're looking at public health, healthcare workforce, and system infrastructure. Again, not only bricks and mortar, but in terms of what is that, what is the type of infrastructure that is going to be needed electronically and otherwise to help us move that needle. Behavioral health. I've talked about how we're in this quadruple pandemic. It's really a syndemic, but it's a quadruple pandemic, not only in terms of COVID-19, but in terms of the racial and social reckoning. And this mental health crisis and the economic crisis that has been impacting lower socioeconomic status individuals, right? Especially communities of color. So you will see a greater emphasis on behavioral health, on mental health equity moving forward, resources being poured into this area so that people who really need help, right? Not just for physical health conditions, but mental health conditions, right? We have to remember brain health is just as important to our systemic health as any other organ.
It's connected to the central nervous system. You mentioned the term syndemics, which really resonates with me, but our audience may not be aware of that term. Can you talk just for 30 seconds on what is a syndemic?
Yes, a syndemic, you're looking at something that has naturally occurred, right? So we can look at the pandemic and then look at the tentacles from that pandemic that touch on other human-made pre-existing inequalities in our society, and that touches upon these issues of structural racism, right, and the like. So that's really what I'm talking about when I'm talking about pandemic.
And they fuel each other.
And they fuel each other.
Each one of the pandemics is worse because of the interaction with others than they would have been independently. So you have this really, kind of stubborn pathology that is made of multiple pathologies. So
that's right. Yeah, you got it. Great way of thinking of it.
So
so mental health. Yeah, exactly. And then we're talking about health insurance. What do we do to, again, health insurance and payment system reforms, right? What are we going to do now to ensure that we can stretch that umbrella of coverage for people who are still lacking health insurance coverage? They fall through our gaps, whether it's owing to states that refuse to expand Medicaid or for other reasons. But there will be an attempt to, again, think about how we can expand public insurance programs as well as private insurance. You'll also see in terms of payment reform, I have long believed, and I think a lot of folks in the Biden administration also believe this, and it's that, when we think about healthcare, in healthcare, these payment and delivery system reforms are really the unfinished business, right, of our movement to advance health equity. And we've been ignoring the intersection of equity and value-based care, right? The issue of equity and quality improvement. We haven't quite gotten it. And folks have ignored it because it is the highest hanging fruit on the tree, right? It's harder to get to, harder to really wrap our arms around. But you will see now, under the leadership of our new CMS administrator and the head of the Office of Health Equity at CMS, LaShawn McKeever, so Chiquita and LaShawn, there will really be an emphasis now on figuring out how do we tie reimbursement, right, to more equitable health outcomes. We want to make sure that health equity is a business model that our healthcare providers cannot refuse to engage in. And the ones that are doing this should be the ones who are rewarded. So you will see greater attention when it comes to technology, the use of telemedicine and the like with CMS. And again, thinking and fleshing out with these providers and payers, et cetera, how we need to move this needle more robustly, because we haven't. Again, we've been nibbling around the edges of the problem. So you're going to see greater emphasis on quality and value and equity, and the reimbursement tied to that moving forward. So that's pretty exciting. Then, because we are in this, once in 100-year pandemic, we are going to be looking at transmission prevention, the issues of access to testing, vaccines, and treatment, moving forward. I'm pretty excited about that. What are lessons that have been learned during this pandemic that we need to be aware of, right? That either maintain the status quo or prevented us from realizing an equitable response, right? We've never been able to achieve an equitable response before in the United States whenever a pandemic has struck us. And it's always the same people who are on the downside of advantage and opportunity who are most negatively impacted. So why is that? We are going to be delving into that to make sure that the next pandemic that strikes will not prevent us from realizing that equitable response. You'll also see for those of your patients and those in your community who are long COVID survivors, there will be more resources and programs that will be developed moving forward to ensure that these individuals have the resources that they need to thrive. So we're going to be, really promoting the recognition, raising awareness, and communicating, and funding treatment for long COVID individuals. You'll also see an emphasis on the safety net, an emphasis on the structural barriers again that have prevented folks from accessing healthcare and resources, social services and the like. So we will be getting into that structural level to figure it out. And we will be working with partners across the country. And then, of course, the last one is proposing rescue or new recommendations to address gaps. So they want to look at what else have we not done that we should be trying, right? Like you'll see an emphasis on now demonstration and pilot projects, for those systems, health systems that have been doing a masterful job, even when the reimbursement wasn't there, but they believed it was the right thing to do. We want to take those lessons and we want to amplify them, and we want to reward these health systems again, right? So it's again scaling what has been done, incubated at local levels, to different levels.
Wow, that's amazing. When is that going to be made public?
Well, I'm hoping by the end of the year,
Okay.
they will make it public.
Thank you.
Yes.
Thank you.
Yes.
Well, this has been fascinating. I could talk to you forever, just mine information and insights and language, but we've come to the end of our time. And I want to thank you, Daniel Dawes, Executive Director of the Satcher Leadership Institute at the Morehouse School of Medicine. Thank you for your time, and I'm sure we'll be in touch.
My pleasure. And thanks again for having me. I appreciate it.
Thank you very much.